Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to part 2, in which we are discussing multiple choice questions and short essay questions regarding inflammatory conditions of the external auditory canal. So let's start today's video. So diffuse otitis externa is also known as, so these are the different options. So as I mentioned in part 1 also, that ideally after listening to or reading to the statement of the multiple choice questions, the answer should click in your mind. But sometimes this is not the situation. So in those cases, you can go for the options and then think about those one by one and rule out. So ultimately you come to the conclusion. So for example, in this case, glue ear we know this is a middle ear condition, and most commonly it is called as otitis media with effusion or secretory otitis media. Necrotizing otitis externa is a separate entity in external ear. Acute suppurative otitis media, as the name indicates, this is a condition of middle ear, so nothing to do with external ear. And cauliflower ear we know is the D-shaping of the pinna after repeated trauma, especially in boxers. So we are left with what it is, telephonist's ear. So diffuse otitis externa synonymously is called telephonist's ear. It is also called as swimmer's ear. The link regarding diffuse otitis externa, it is there in the description. You can check it out for more details. Otitis externa haemorrhagica is caused by, now different options are there, and we know that this is a viral infection. So some virus would be the culprit for this otitis externa haemorrhagica. If we cannot pick it straightforward, or we are not sure about that, either it is influenza or some other. If we look at the options, all four other options, they are bacteria: strepto, proteus, pseudo. So only viral infection which is mentioned here in the options, that is influenza. So that is the answer. And we know that this otitis externa haemorrhagica, it is more prevalent in those areas where there are epidemics of influenza, and it is usually occur during an acute attack of upper respiratory tract infection, or it follows the attack of upper respiratory tract infection, which may be cured till the presentation as otitis externa haemorrhagica. Now this is an old lady, as you can see in the picture. If you closely observe, there are certain findings just by looking at. For example, if we go for the forehead, we can see that the forehead on the left side, it is flat. There are no furrows, natural furrows, which are the wrinklings of the forehead, which are there when we look upwards, which are present in this lady also on the right side, but on the left side it is flat. Right eye she is able to close, while left eye it is open, she could not close it properly. If we compare the nasolabial folds bilaterally, you can see the nasolabial fold normally is present on the right side, but on the left side it is not that much prominent or almost absent. This angle of the mouth is dropped. She could not move this angle of mouth, while on the right side she can pull it upwards. So we can say that there is complete paralysis of the facial nerve which is supplying the muscles of facial expression on the left side. So when whole half of the face is involved, it means that it is the facial nerve paralysis, lower motor neuron type. So when this lady last year, she presented in our clinic, and when we investigated her, she gave us the history, which I will show you in the next slide. But on examination, this same lady on the left side of the ear, this was the condition. And if you closely observe her pinna and external auditory canal, you would be able to see that there is crusting here in the concha, and there is some healed, you can say, vesicles or lesions which are present here, and this one is almost healing now. And similarly, there were some vesicles and crusted areas there in the external auditory canal as well. So let's see what was the history of this patient. She was 53 years old, female, presented with the left earache and left facial paralysis from last 6 days. And on examination, as I showed you, there were crusted lesions and vesicles in the external auditory canal, pinna, and the neck. So what is the most likely diagnosis? Because already the problem is there from last 6 days. So she is already in, you can say, in healing phase. So that's why we see some crusted lesions, some healed lesions already. So with vesicles, which are there in the concha especially, but involving the external auditory canal with facial nerve paralysis, that's what we call as Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is equal to herpes zoster oticus plus facial nerve paralysis. As far as treatment is concerned, again the link about this herpes zoster oticus and Ramsay-Hunt syndrome will be there in the description, so you can check it out there. Moving on, a patient presented with severe pain in the ear and unilateral facial nerve paralysis. Examination again showed vesicles on ipsilateral pinna and in the ear canal. So diagnosis is this. So as we just discussed in the previous slide with that lady, almost same picture is here also, that there are vesicles which are involving the external auditory canal and the pinna along with facial nerve paralysis. So that's what it is called as herpes zoster oticus. If you could not pick up the answer from the statement, again to the basic concept, let's go one by one for all these options. As far as this Bell's palsy is concerned, we know that Bell's palsy is a diagnosis of exclusion. Bell's palsy is unilateral lower motor neuron facial palsy, but this is the diagnosis of exclusion. When we say some disease is diagnosis of exclusion, it means each and every possible cause of that particular disease should be ruled out. Secondly, in Bell's palsy, there is no vesicle formation. Malignant otitis externa, we know that it is a disease of the external ear. Facial nerve can be involved there, but in that case, there are no vesicles. Rather, there will be granulations, and those granulations will be present and usually at the floor of the external auditory canal at osteocartilaginous junction. Keratosis obturans is a deep meatus disease where there is keratin deposition in the deep meatus, and there may be widening of the deep bony part of the external auditory canal. Myringitis bullosa, that is a close contestant with herpes zoster oticus, but in case of Myringitis bullosa, there are the vesicles which are one thing blood filled rather than fluid filled vesicles as in case of herpes zoster. Second, in case of Myringitis bullosa, the vesicles, blood-filled vesicles, they are confined to the outer surface of the tympanic membrane and deep meatus only. The vesicles in case of Myringitis bullosa or Myringitis bullosa haemorrhagica or Otitis externa haemorrhagica, synonymously these are called, are confined to outer layer of tympanic membrane and deeper part of the bony meatus. They don't involve the pinna. While in case of herpes zoster oticus, the fluid-filled vesicles, they involve the tympanic membrane, deep meatus, outer meatus, pinna, even to the cheek and neck also. So the answer here it is because there is vesicles which are involving the pinna and the external auditory canal and facial nerve paralysis. So this is what it is called herpes zoster oticus. An adult presents with acute otalgia with blood-filled vesicles on the tympanic membrane and deep meatus. The diagnosis is, just I discussed in the last slide, this is Myringitis bullosa haemorrhagica or Otitis externa haemorrhagica. So let's see what are the options, because Myringitis bullosa haemorrhagica, in this there are blood-filled vesicles confined to the superficial layer of the tympanic membrane and deep meatus, no facial palsy, no involvement of the pinna and the skin of the cheeks or the neck. This link for the Otitis externa haemorrhagica will also be there in the description. You can check it out. A 30 years old lady had flu, which was followed by severe otalgia and tinnitus. One day later, she had blood-stained discharge from the left ear and on otoscopy had reddish vesicles on eardrum. So again, a typical history of Myringitis bullosa haemorrhagica or Otitis externa haemorrhagica, that she had the flu. So it is usually there caused by the virus which are responsible for upper respiratory tract infections. It is more prevalent in epidemics of influenza. So same is the case here. Blood-filled vesicles are there. They are prone to rupture, and when they rupture, there is blood-stained discharge, which we can say serosanguinous discharge is there, which happened in this case also. So the diagnosis is Otitis externa haemorrhagica or Myringitis bullosa haemorrhagica. Now, treatment, you can check it out from the link regarding Otitis externa haemorrhagica. What is Ramsay-Hunt syndrome? So sometimes in SEQs, keep in mind, they will ask you the questions which will be in relation with the statement which is provided there. And some part of the question or 2 or 3 parts of the questions being asked, they may be theoretical. So as in this case, you can see part A and part B question, they are related with this statement which is mentioned above, while this part C question, it is purely theoretical. You can say it may be in the differential diagnosis of this statement, but not directly related with. Here it is being asked, what is Ramsay-Hunt syndrome? So repeatedly we have discussed in this video that Ramsay-Hunt syndrome is basically herpes zoster oticus plus facial nerve paralysis. And in herpes zoster oticus, there are fluid-filled vesicles, not blood-filled vesicles. So when there will be discharge after bursting those vesicles, that discharge will transparent and watery, and those vesicles, they are present not only on the tympanic membrane and deep meatus, but they will be involving the pinna and the skin of the face and the neck as well. All of the followings are used in otomycosis except. So here if we go one by one, 2% salicylic acid and rectified spirit, it is a keratolytic agent which is helpful in the treatment of fungus. So this is antifungal. 1% gentian violet in alcohol, again alcohol it is there. So keratolytic agent, it is again helpful in fungal treatment. Clotrimazole itself is an antifungal agent. So what is the odd one? 5% soda bicarb in glycerine, which is actually waxolytic, that it is used to soften the hard wax. So A, C and D, they are antifungal agents. while B is not an antifungal, so will not be used in case of otomycosis. So hopefully everything is right on your part also. So thank you very much.